For decades, cardiovascular risk assessment has revolved around two numbers: LDL, bad cholesterol, and HDL, good cholesterol. These markers have dominated the conversation in clinical practice, nutrition guidelines, and pharmaceutical strategies. Lower the LDL, raise the HDL. That's been the mantra. And for a while, it seemed to work. But then along came niacin, a vitamin capable of doing both. High-dose niacin can slash LDL, skyrocket HDL, and yet fail to reduce heart attacks or strokes. Even worse, it sometimes increases adverse outcomes like insulin resistance or new-onset diabetes. This is not a bug in the system. It's a clue that the system itself needs rethinking. The niacin paradox is one of the most compelling examples of why relying solely on lipid profiles to assess cardiovascular health is dangerously outdated. If a drug or nutrient improves your LDL and HDL numbers on paper but doesn't reduce mortality, or worse, increases risk, then it's time to question whether those numbers are telling the full story. Let's start with HDL. Once hailed as the heart's protector, HDL is now facing an identity crisis. Studies that aim to pharmacologically raise HDL through niacin or CETP inhibitors failed to show benefit.
Why?
Because HDL function matters more than HDL quantity. A high HDL level doesn't guarantee that your reverse cholesterol transport system is working properly or that your HDL particles are anti-inflammatory. In some people, especially those with metabolic dysfunction or chronic inflammation, HDL becomes dysfunctional, more like a rusty garbage truck than a cellular janitor. As for LDL, lowering it does correlate with reduced cardiovascular events in many populations, especially with statin use. But LDL tells you nothing about the quality, oxidation state, or particle number and size of those lipoproteins. Small, dense LDL particles are more atherogenic than large, buoyant ones. And oxidized LDL, unmeasured on standard panels, is particularly dangerous. So an LDL-C of 100 milligrams per deciliter means something very different in an inflamed, insulin-resistant person than it does in a metabolically healthy athlete. This is where newer biomarkers come in, tools that offer a more nuanced, biologically relevant view of cardiovascular risk. First up is LP(a), or lipoprotein A, a genetically determined lipoprotein that's structurally similar to LDL but far more atherogenic due to its sticky, pro-inflammatory nature. Elevated LP(a) is now recognized as an independent and heritable risk factor for cardiovascular disease, including aortic stenosis. It's not influenced by lifestyle or diet and barely budges with statins. And niacin? It's one of the only substances that can lower LP, but again, the outcomes have been underwhelming because it seems that mechanism matters more than metrics. Then there's hsCRP, high-sensitivity C-reactive protein, a marker of systemic inflammation. Chronic, low-grade inflammation, not just high LDL, is the true driver of atherosclerosis. Plaques don't just build up from fat. They're inflamed, active lesions triggered by immune dysfunction, oxidative stress, and endothelial injury. Elevated hsCRP predicts cardiovascular events even when LDL levels are low. And interventions that reduce hsCRP, like statins, plant-based diets, or certain anti-inflammatory drugs, can improve outcomes, even without dramatic lipid shifts. And what about endothelial function? This is the real frontline of cardiovascular health, the ability of your blood vessels to dilate, respond to nitric oxide, and maintain a non-inflammatory, antithrombotic surface. Endothelial dysfunction is an early sign of atherosclerosis and predicts future cardiovascular events far more accurately than cholesterol levels. It reflects the cumulative impact of oxidative stress, hyperglycemia, insulin resistance, blood pressure, and toxic lipid particles, a real-time report card on vascular integrity. Tests like flow-mediated dilation, FMD, or reactive hyperemia index, RHI, are emerging as tools to assess this, though still mostly in research settings. The point is this: cardiovascular disease is a complex, inflammatory, and metabolic condition. Reducing it to two static numbers, LDL and HDL, is a convenient oversimplification, but it's no longer scientifically defensible. The niacin paradox exposed the cracks in that framework. If a compound that perfects the lipid panel can still increase risk, then we need to stop worshiping the panel and start listening to the physiology. A better approach would integrate traditional lipids with advanced markers like ApoB, a better proxy for LDL particle count, LP-A, oxidized LDL, HSCRP, insulin sensitivity metrics, and vascular function tests. Add in genetic data, gut microbiome influences, and lifestyle factors like sleep, stress, and circadian rhythm, and suddenly you're approaching a truly personalized cardiovascular risk model. So yes, lipids still matter, but they're just part of the story. The next era of heart disease prevention will be defined not by how low you can drive your LDL, but by how resilient your vasculature is, how quiet your immune system is, and how metabolically flexible your body remains under stress. In the end, the most dangerous cholesterol is the one that convinces us we're safe just because our lab numbers look good. The niacin paradox reminds us that we need to dig deeper and redefine what heart health actually means.